Hello and welcome to my Sunday morning coffee talk. Um, Today, I'm going to be discussing the assessment of attachment related pathology surrounding divorce. That's this booklet. Um, and next week, I plan to discuss the contingent visitation schedule, uh, which is a strategic family systems intervention for the pathology. And so these are two resources that I developed for parents to be able to provide to mental health people, to the courts, or just to orient you to the what needs to happen in terms of the assessment of the pathology in the family courts. So each one of them I wrote to be about 50 pages long for each of these. And then at the beginning, I put a description of the pathology before getting into the assessment or before describing the contingent visitation schedule. And but in each one, I described it from a slightly different angle. So if you're handing these out to people, uh, that will provide an explanation of the pathology from different perspectives. The other booklet that I wrote for you to make available is just the narcissistic parent, and this one is just to hand out to the legal professionals to acquaint them with the literature or the scientific literature on the narcissistic personality and relative to their role as a parent. I used quotes from the literature and then provided the connecting sentences between the quotes and organized them into topics. So this is your general education booklet about the narcissistic parent and what's going on with the pathology. But then these two I wrote specifically to help the mental health professionals, but also the court in understanding things. It's deeply, deeply problematic when the patients are explaining the pathology to the doctor, but that's the current state of professional psychology in the family courts. It is abysmal. So the doctor should always be explaining the pathology to the patient, never the patient to the doctor. But that's the state of the situation. And as I talk about the assessment of attachment related pathology, um, and this pathology, it's also um, persecutory delusional disorder. And when I talk about the assessment of it, there's other assessment approaches like the mental status exam for thought and perception of a delusional pathology, or parenting assessments that look at parenting strategies like response cost, timeout, angry parenting, negotiation. You can assess for those using an applied behavioral analysis um, and behavior chain interviewing. It's called a behavior chain and applied behavioral analysis. Now, that's from behavioral psychology from the 1940s and 50s, B.F. Skinner and his little rats and teaching rats to press a lever. All of that about rewards and reinforcement and punishments and all that behavioral psychology from the 1940s. That's called applied behavioral analysis. And it should be conducted with this pathology in the family courts. It's very simple. You do before, during, and after what the person's feeling, thinking, and doing, and you develop an understanding for what's cueing the behavior, what's triggering the behavior, what are the cues and what are the reinforcers. Behavioral psychology is the B in CBT, cognitive behavior therapy, which is the dominant paradigm right now. The cognitive therapy is Aaron Beck, and the behavioral is B.F. Skinner, and the T is the therapy. So CBT, B is the behavioral therapy of applied behavioral analysis. And there's not a single forensic psychologist who knows applied behavioral analysis in the family courts. So yeah, we have to educate them about psychology from the 1940s and 50s that is foundational to behavior therapy, and they're ignorant like a rock. So one of my favorite sayings, don't try to teach a pig to sing, it just frustrates you and annoys the pig. But unfortunately, there's no competent mental health professionals in the family courts. And where the licensing boards need to start enforcing competence standards so we get competent mental health people. And the APA needs to get over here because holy cow, the forensic psychologists are going to be hopefully leaving. I cite to the New York Blue Ribbon Commission on Forensic Custody Evaluations. And I'm in the family courts right now reviewing them line by line, their custody evaluations, and they're all in violation of ethical standards and failure and duty to protect. So they're going to be looking at board complaints and malpractice lawsuits potentially. And the moment everybody acknowledges that the diagnosis is child psychological abuse and it's potentially a shared persecutory delusion, it's a differential diagnosis one way or the other. But if it's a shared persecutory delusion, that's child psychological abuse. They will be admitting that they haven't done that the entire time, that they have been misdiagnosing child psychological abuse because they have not been assessing for the shared persecutory delusion. And the moment they do that, they admit that for the last 40 years, they have been unethical, incompetent, and misdiagnosing child abuse, which is going to be a problem for like the forensic psychologists like Sullivan and Deutsch and Stahl and Simon and all the forensic psychologists, uh, because, and especially if you've been here for a while, because it's an acknowledgement that you have misdiagnosed child abuse for your entire career because you're not competent in the assessment of delusional thought disorders or in the assessment of attachment pathology. The only place you get knowledge of attachment and attachment pathology is early childhood because you never see attachment pathology in older children outside of the family courts. Okay, it's a unique feature of the family courts that we have severe attachment pathology develop in later childhood. You never see that. Attachment pathology is in early childhood. And what we see in later childhood is a stabilized attachment system from early childhood. We never see severe attachment pathology spontaneously develop in later childhood that doesn't have a history of prior um, display from early childhood, which indicates to me that is likely a false attachment pathology, since it doesn't, the prevalence of it in outside the family courts is zero. But none of the forensic psychologists know that because they don't work outside the family courts and they don't work early childhood or know anything about the attachment system. So they're in violation of ethical standards regarding delusional thought disorders and regarding attachment pathology. And I know that for a fact because the only way you get experience and training in the assessment of delusional thought disorders is over in schizophrenia. And the only place you get training and knowledge about attachment pathology is early childhood mental health. And they have neither of those. I have both of those. So I am a scaffold from the current state of ignorance to a state of knowledge and the application of knowledge. But if they don't want to use my assistance and my knowledge in scaffolding their ignorance and incompetence, well, then they can do a mental status exam of thought and perception and apply behavioral analysis and behavior chain interviewing to determine the cue structure of the child's problem behavior. It's like, they're just ignorant like a rock. So what I did, because I know they're ignorant like a rock, and I say they're not assessing, I gave you an assessment protocol. What Dr. Childress would recommend as an assessment protocol to develop the diagnosis. Now, these are the two diagnostic uh, instruments that I have. They're not assessments; they're symptom documentation instruments. So we have the diagnostic checklist for pathogenic parenting. 3 symptoms. The, is there attachment suppression towards a normal range parent? Symptom 2 is high anger or high anxiety protest behavior. That's 5 narcissistic symptoms, or a parent phobia, an unrealistic parent phobia. And 3 is a persecutory delusion from the child. And then there's the 12 associated clinical signs on that. But these 3 diagnostic indicators, the attachment pathology, extreme protest behavior, and a persecutory delusion, are only show up with this particular, the shared persecutory delusion and false attachment pathology. It doesn't show, these symptoms are impossible symptoms. They never show, the prevalence in the general population for all of these symptoms is 0. We never see them. So if we're seeing all 3 of these symptoms, there's only one explanation. But then, in order to collect the necessary information to complete this, I gave you a 6-session structured assessment protocol. This is what I would recommend to be able to collect this information. And then the parenting practices rating scale, that's the applied behavioral analysis part. The parenting practices rating scale is to document that the targeted parent is a normal range parent, because that's criteria 1 is attachment suppression towards a normal range parent. Well, are they targeted parent a normal range parent? Complete the mental health person does a little checklist, does a parenting assessment. Using applied behavioral analysis would be my recommendation, but they don't know how to do that. But so you rate the targeted parents parenting. And these are either levels 1 or level 2, which is abusive range, or levels 3 and 4, which is broadly normal range. And if the parent's level 3 or 4, broadly normal range, then they cannot be producing the attachment pathology of symptom 1. So these are the 2 symptom documentation instruments that can develop a standardized assessment protocol, so that all mental health people are collecting at least some basic information. They can collect more than this, hopefully they do, but at least we have a consistency across all mental health professionals in documenting one half of the differential diagnosis. Is the allied parent psychologically abusing the child? This will answer that question. But then the other differential is that the targeted parent is somehow abusing the child, which then would require professional experience in complex trauma and child abuse, so that you can properly assess for child abuse by the targeted parent. They don't have any background. The forensic people don't have any background in complex trauma and child abuse. They just work in the family courts. So they're missing delusional thought disorder competence, they're missing attachment competence, and they're missing complex trauma and child abuse competence. Now, I worked in the foster care system. I have early childhood mental health expertise, and I'm out of schizophrenia for 12 years. So I have that knowledge. I can provide you a scaffolding support if you want to use it. If the mental health professionals are lazy, ignorant, lazy, incompetent, and unethical, then fine, you can do a mental status exam with thought perception and applied behavioral analysis and a proper risk assessment for possible child abuse to the differential diagnosis for each parent. So this booklet is what I would suggest as a standardized assessment protocol. It can be adjusted a little bit, but the standardized assessment protocol, it's 6 sessions for the mental health people who are ignorant and incompetent and are wanting to scaffold into competence. Now, when I conduct assessments, I don't need 6 sessions. It's a mental status exam with thought perception. And I can do that in a 45-minute session with the pathological parent. So, for example, there was one time a parent got me court ordered to conduct the assessment, and they flew me into the local area. It was in California, so I'm licensed in California. So they flew me in, and it was a mother, father, and about a 8 to 10 year old child, and there's false allegations of abuse. At least that's what I'm being brought in to assess for. Are there false allegations of abuse? Is there this shared persecutory delusion? Now, for that situation, I conducted the entire assessment in one day. I met with the mother, who was the allied parent, for about an hour and a half with a court reporter present. That was pretty interesting. And with the opposing counsel present, which was also pretty interesting. So I met with the mother for about an hour and a half, conducted a mental status exam of thought and perception. And yes, she had a persecutory delusion. Because I had a court reporter present, I had it all documented, so I can show the judge exactly where I popped the delusion out. We don't diagnose delusional thought disorders based on history. We actually pop them out during the session. That's the mental status exam of thought perception. It's a linear approach to the interviewing, and doesn't let the person get off into associational thinking. You're keeping them on a linear line to things. And so when you do that, their delusion will pop out. It will show up first in contradictions and move to denial. And if you keep on it, it'll actually go into a slight dissociative state. And so I conducted a mental status exam of thought and perception, popped the delusion out, and it's now in the transcript by the court reporter, and I can show the judge exactly where the thought disorder is in the process. And so that's an hour and a half interview with the pathological parent. You can do it about 45 minutes, but in this court-involved situation, I'd recommend an hour and a half with these interviews. An hour and a half, 90 minutes is a nice arc. 60 minutes is just a little too short for a good clinical interview. So I do the mental status exam of thought perception with the parent, and then the child came in, and I did about a 45-minute, half an hour, 45-minute assessment with the child. Similar mental status exam, but it's gentler with the child. I'm just confirming the delusion that the parent has, that they share the same belief that the child is being malevolently treated in some way. So I get most of the reporting and the delusional pathology out of the parent, and I confirm it with the child. And that's part of the reason I want to be in the room when I do these assessments. People ask, can you do them online? No, because it's a sensitive interview with the child. I want to be in the room and kind of holding the child's emotional experience as I explore the child's reasoning and things. And so I can conduct an assessment like this in a day. Another case I was brought into was a family of like 4 adolescents. Another case in California, court ordered come in for the assessment, brought me into the region. And that took me, I think, 3 days. So I stayed over 3 days, and I met with all the kids. I met with the mom and dad. I met with everybody over 3 days. But that was, 4 children, adolescent children. But it was done within a week. My assessment was done within a week. Okay, so it's this idea of 6 sessions, spread over 4 to 6 weeks, is what I'm sort of structuring up, because the mental health people don't know how to do anything: risk assessments, applied behavioral analysis, mental status exam, those sorts of things. So what the other goal I had in this, because it's not enough to just tell people what they're doing wrong, you have to also tell them what to do instead. So this is my what to do instead. In this, based on my knowledge and experience. Now, again, for me, because I'm competent, I can make the diagnosis on any one of these three symptoms. Okay, the delusional disorder, that's a mental status exam of thought and perception. Attachment pathology, it's a false attachment pathology right off the bat. And I know how the attachment system works. It's always maintains the goal of forming an attachment bond. So is it disorganized attachment, no organized strategy, um, ambivalent attachment, high protest, or avoidant attachment, low protest? And those are really the only types of attachment pathology, three categories. Insecure attachment pathology, disorganized, ambivalent, or avoidant. Uh, Disorganized, the child has no organized strategy to bond to the parent. That's the child's display of attachment pathology relative to the targeted parent. The child has no organized approach to forming a healthy, secure attachment bond to the parent. So they have a disorganized attachment to the parent. Now, that would be consistent with child abuse. Child abuse produces a disorganized attachment. The child doesn't have any organized strategy to bond to an abusive parent. Um, and that is caused, the disorganized attachment is caused by frightened or frightening parenting. Frightened or frightening. So the parent is responding to things that aren't there, and so they're frightened, and the child's going, what's going on, and can't organize their bonding to a parent who's afraid or giving off high fear cues. Or a frightening parent, that's your abusive parent, where the child can't bond to the parent because they're frightening. So a frightening parent is what produces a disorganized attachment. And I'll cite Lyons Ruth um, in all her research on disorganized attachment. Now, when we then look at the targeted parents parenting, they're not frightened or frightening. Okay, they're a normal range parent. So that parent cannot be producing the disorganized attachment, because we know what produces disorganized attachment is child abuse, and that parent's not abusing the child. So that's a false attachment pathology. What is the actual? Well, the disorganized attachment was with the allied parent, and then we have an enmeshed relationship and a delusional disorder, the frightened and frightening parenting. And so we have a disorganized attachment, a false disorganized attachment being created in the child. So from my perspective, I come in on symptom one, the attachment system, and I can recognize it's a false attachment pathology. But the mental health people in the family courts don't know anything about attachment, so that's beyond their ability to do. Narcissistic symptoms, specific phobia in a child, those are impossible symptoms in childhood. Narcissistic symptoms are an adult pathology. Narcissistic personality disorder in childhood, what later develops into narcissistic personality disorder, is an attachment pathology. We see insecure attachment. For the narcissistic, we see insecure avoidant attachment. For the borderline, we'll see the borderline spectrum. We'll see insecure ambivalent attachment in childhood. As they move into young adulthood, the attachment system crystallizes out into the personality structures, and we get the various personality disorders of adulthood. We don't see personality disorders in children, but holy cow, with this pathology, yes, we do. We see five specific narcissistic traits in the child. These are the fingerprints of psychological control by a narcissistic parent. Or we see a specific phobia, a parent phobia, which is unrealistic. Children don't develop a mother phobia or father phobia. But sure enough, the child's symptoms meet DSM criteria for a specific phobia, a parent phobia, which is unrealistic. So, we can make, and then the delusional disorder is, shared persecutory delusion. Child never develops a delusion towards a normal range parent. So I can make the diagnosis on any one of those three symptoms, but I gave three of them to the incompetent mental health people, just to help them, to reassure them that yes, this is really the pathology. If all three of them are present, there's only one explanation, because all three are impossible symptoms, but all three will show up with a false attachment pathology, a factitious disorder imposed on another. Uh, and so, how would I recommend generally in the courts for them to assess the mental health people? What's a structured assessment protocol? So I basically recommend 6 sessions. The first two are with the parents to gather background history information, and I typically would recommend you start with the allied parent. We want to get all the worst possible reporting on the parenting of the targeted parent, because our differential diagnosis is child abuse by the targeted parent. And so that's our first one we want to rule out. That's the high risk one. We say, oh, the child's rejecting a parent. Well, is that parent doing something abusive? Physical abuse, sexual abuse, neglect abuse wouldn't really produce that, or psychological child abuse. So, is the targeted parent abusive? Is our first rule out. So, we'll get that information, not from the child initially. I don't want the child necessarily bad mouthing or being negative about the parent. I do. I mean, I want the child's reporting, but I want to minimize that as much as possible for inverted hierarchy for a number of reasons. So I will get the most of the primary information from the reporting of the allied parent. So the allied parent, meet with them first, hour and a half, and my goal is to obtain the reports of the worst possible parenting by the targeted parent. Are we talking of abusive range? And when they bring this up, I will conduct a mental status exam of why do you believe the child is being abused? What's the reasons for your belief? And that's what the mental status exam is. It's not about what the person believes, it's about how they reached that conclusion. Because normal range thinking, linear and logical reasoning, follows from the evidence to reach the conclusion. But a delusion does it reverse. It starts with the conclusion as fixed and then constructs the evidence or supposed evidence to then match the fixed and false conclusion. And so, what we're looking for is not what the person believes, but how did they reach that decision? Are there sort of a linear logical steps to their reasoning? Maybe not right, but at least there's reasoning involved with it. Or is it emotional thinking, associational thinking, it's called, where they start to go down a linear path, but then go sideways. And so it's not a logical sequence. And it's that sideways move called associational thinking, triggered by emotional responding. Is that sideways where the thought disorder is. That's where it's not linear and logical. And it goes to the delusional belief. They have this fixed belief that the child is being malevolently treated in some way, that the child is being abused somehow. That's not true. And then they construct the evidence. So if you try to get a linear line to how they reach that, there's no there. And that's what the mental status exam does. And so that would be the first session with the allied parent. I'm doing a differential on that, is whether or not the targeted parent is abusive range, or are we looking at a persecutory delusion in the parent. The next thing I will do, so I'll get all the worst possible criticisms of the targeted parent in session one. Then in session two, I'll meet with the targeted parent and I'll have a list and say, okay, so here are the concerns. There was this event, there was this thing, there was that thing, there was this, and I will get the response of the targeted parent and see if they provide something that's linear logical reasoning, or whether they're kind of being evasive or not quite linear and logical in their stuff. And that's where it's important for the clinician to have a background in complex trauma and child abuse. Because when we're interviewing the targeted parent, that could potentially be a narcissistic, um, borderline, but more likely the narcissistic parent who's abusing the child. And we have to know what the narcissistic child abuser personality looks like, how they respond in clinical interviews, how to assess for that personality. And we get the applied behavioral analysis of the specific reporting. These are specific incidents. How do you respond? And so then we're looking at the targeted parent and how they respond. Now, if off of those two assessments, we're not hearing child abuse from the targeted parent, we're hearing normal range kind of parenting, an inverted hierarchy, judging the parent as if the parent were the child and the child were the parent, cross generational coalition, enmeshment. We're hearing a lot of symptoms that place it with the targeted parent rather than with the allied parent rather than with the targeted parent. Um, that's our initial kind of framing of the two sessions. So now I got the background information regarding the two. Now, for older children, probably above 12 or so, I will meet with the child individually for a session, and I will want to get confirmation of the allied parents' concerns. So, are these your concerns? I'm looking at for potentially the shared persecutory delusion. If one parent has a delusion, does the child believe it? But also, I want to get the child's reporting of the worst possible parenting that they've experienced from the targeted parent. And so, what is the worst possible thing? Because I'm going to use that in the next session to assess the family dynamic. So, what is the child's concerns? And especially for like a 12, 13, 14, 15-year old young person, I'm going to want to hear what they have to say and get it straight from them what's going on. I'm looking at for possible physical abuse, possible sexual abuse, or possible psychological abuse. Neglect is in the ballpark, but neglect doesn't produce the severity of attachment pathology like we see a child rejecting a parent. It shows up differently when you have a meth mom or you know alcoholic dad or something that's neglectful, no food in the house, those sorts of things. That shows up differently. So then I'll meet with the child. For younger children, I might meet with them, but typically not. It's just a little too early to. They don't have enough cognitive structure to be able to describe things with any accuracy. So then the fourth session is I will meet with the targeted parent and the child together. Now, this gives me the opportunity to see the symptoms on full display, both the symptoms or the reporting of the about the targeted parent, but also the child's symptoms of fear or rejection or those sorts of things. So I get to see the symptoms in display, and because I've done the preparatory interviews with the allied parent and the targeted parent and the older child, I'm prepared for that session to keep a lid on it if it gets difficult, but it doesn't get difficult. There's no, I've never, it's irrational to think that the targeted parent is going to come in and start verbally abusing the child in my session or beat the child so I'm not going to see like child abuse in my session. And so it's a safe environment. I'm sitting there. But I also want to, if I'm going into a tense situation with a child, I want to have all my background information all set up before I go into that. So then that fourth session, I put the parent and child together, and in this session, I work. I don't have the parent and child talk to each other so much because then things can go haywire and wrong in their communication. I'll have them talk through me, boom, boom. And so it's like a little V that goes, and that way I can modulate the situation and keep everything under control. And mostly what I'm doing is that I tell the child, you can kind of sit back because I've already talked with you. I've talked with mom. I've talked with dad. I've talked with everybody. And what I'm going to do is I'm going to carry your voice, your complaints, the child's complaints to the targeted parent. We're going to see how they respond. And so if I'm going to carry your voice. If I'm not getting it right, please correct me. But I'm going to see how they respond. So then I'm going to present to the targeted parent the child's criticisms and critique and say, so how do you respond to that? And then if there, I might push a little bit and say, well, the child thinks there's a, well, what do you think? And so I'll push that the targeted parent a little bit with what the child is saying. That allows the child to sit back and just kind of hear the arguments and hear the parent response without having to be the focus of it. And so they get to just listen to me carrying their voice to the targeted parent. And then the parent gets to respond. And I kind of draw that parent out and get a nice full response. And then I take the targeted parent's response, I turn to the child and say, okay, so you just heard what the parent said. And here's, what they said. And so what's your response to that? And then the child gives their response, and I kind of explore that with the child. And is that reasonable? Is that right? What are they thinking? What are they wanting? And explore that with the child. And then I'll take that and go back to the target parent. She said, you just heard what the child said. What's your response in here? And I'll go back and forth like that. And in that process, about a third of the way through, I'll start stuff called response to intervention. So as I'm moving the dialogue back and forth between the two of them through me, I'm the conduit for that. As I'm doing that, I will begin to do some interventions with the targeted parent. So the child will say, "Oh, they're so angry and they were yelling at me and stuff." And I say, "So you would like your parent, your dad, to be not as angry, okay? So you would like to have a loving, positive relationship with your dad where he was just happy and smiling all the time." And the child goes, "What? Wait, no, but that's what." So I say, "Can you do that? Can you smile at him?" And I'll actually change the targeted behavior, target parent's behavior. I'll say, "Do something different to the child." Now that's behavioral psychology. I'm changing the cue to the child. I should see a change in the child's behavior. Let me take a sidestep for a second, talk about something called stimulus control. It's again out of behavioral psychology from the 1940s to 1960s. So let me educate you about it because the mental health people are ignorant like a rock. Stimulus control. What that means is that our behavior is controlled by the cue, not the consequence. Behavior is controlled by the cue, the trigger, not the consequence, not the reward or punishment. And when we teach this concept, and I've taught it in therapy, behavior therapy courses and stuff, when we teach the concept of stimulus control, the typical example that we use is the traffic light and driving. So our driving behavior is not under the control of you know accidents. While the consequence, while we want to avoid accidents, we don't drive around going, "Am I going to get in an accident?" We follow rules, lines in the highway and stuff. And one of the cues is the traffic light, the most important cue, so that when the light is red, we stop. When the light is green, we go. So our behavior is under the control, or a response is under the control of the stimulus of the traffic light. The stimulus of the traffic light has control over our driving behavior. That's stimulus control. And if the light is red, we stop, green, we go, yellow is a transitional warning. So now, if I change the color of the traffic light, I should see a corresponding change in the behavior. But if I change the traffic light and there's the person just ignores it and just does whatever they want, and they're not responding to the red, green, or yellow, then their driving behavior is not under the control of the stimulus. It's not. And so that's, is a child's behavior in authentic parent child conflict. The child's response to the targeted parent is under the control of that stimulus of the targeted parent. The targeted parent is cueing or triggering the child's response. Now, that means if I change the behavior of the targeted parent, if I change what their cue, what they're presenting the child, they change the color of their traffic light, then I should see a corresponding change in the child's behavior. That's behavioral psychology and stimulus control. If I don't see a corresponding change in the child, or I change the parent but don't see any change in the child, then the child's behavior is not under the control of the parental stimulus. So I can change the parent behavior to red, green, blue, magenta. It doesn't matter what I do with the parenting behavior because it's not going to affect the child because it's not authentic. It's not cueing the child's behavior. Well, then what is the cue for the child's behavior? The alliance and loyalty to the allied parent. And so it's a three-person triangle, not a two-person causality. And so that's the other differential. Is it two-person causality for the child's behavior? That's the child and allied parent's assertion that the targeted parent is causing the child's attachment pathology, two-person attribution. The targeted parent is saying, no, it's a three-person triangle attribution of causality. That's Murray Bowen, family evaluation. I'm surprised that we have people in the family courts doing family evaluations have never read Murray Bowen family evaluation. Top family systems person, you're assessing a family and you've never read family evaluations. Holy cow. So the concern is a triangle. And so if the child's behavior isn't under the stimulus control of the parent, then we have a triangle causality to the situation. So in that fourth session, that's what I'm looking at, part of what I'm looking at. About the third to halfway through the session, I'll start to do a few minor response to interventions. I'll ask the parent to do things, see how the child responds, see what the cue structure is, and if there's stimulus control over the situation. Get the parent response, see if that's authentic, see if it's reasonable, if the targeted parent's giving me reasonable responses, and look at the child. And if you're looking for a mental status exam, if you read the Martin quote on that, does the child have reason? Are the fears that the child is expressing and the concerns, are they reasonable or are they exaggerated with no discernible basis in reality, kind of thing? And so I'm looking at the thought processes and emotional processes of the child. And because I know attachment, I know how that should look like. So after about the fourth session, I have the diagnosis. We got all the symptoms. I got the persecutory delusion, or I've got the child abuse pretty well clear from the targeted parent. And so after the fourth session, I kind of have clarity on what's going on. And when it's the shared persecutory delusion side of things, then the fifth session, I will meet again with the allied parent. And in that session, I give them feedback about what I've discovered in the session. This is my opinion, that we're looking at whatever. And at that point, I'm looking at the response of the allied parent. Are they able to take in information? Are they able to process information? Or does it just simply bounce off their delusion, their persecutory delusion? And when I, in my fifth session, suggest that we develop a treatment plan for restoring the healthy attachment bond to the targeted parent, you'll see the allied parent just escalate up. No, we can't do that because whoop, up they go, because they cannot tolerate that outcome of a bonded relationship with the targeted parent for a variety of reasons. And so I'm doing my final assessment with them, seeing how they respond to that situation. I will typically use the first four sessions to develop a rough treatment plan. This is what I suggest for the treatment plan. This is how we do it. And I present that to the allied parent and see how now every normal range parent, when I present a treatment plan to fix their child's attachment pathology by making the other parent just a wonderful parent, oh my goodness, we're going to make them such a wonderful parent. Your child's going to be going to school and telling all their friends, I have the greatest mom or I have the greatest dad. We're going to make them into a wonderful parent. Won't that be great? No, it won't. All normal range parents will say absolutely. And I've worked with normal range parents with the narcissistic, abusive kind of parent or borderline kind of parent, and they're worried. They want their child to bond to that parent. And so if I come up with a treatment plan to do that, they're very happy about that. But with this pathology, if I come up with a treatment plan to fix the child's attachment pathology, the allied parent's not going to agree to that. And that's where you start the resistance again. So I'm using those 6 sessions in a way, in a structured way, to gather the information that I need. What the forensic psychologists do in their assessments, they just tape record a, just tell me about the thing, and it's just an unfocused interview. They have no idea what they're looking for, and so that you just get hours of transcripts and their reports, paraphrase transcripts of unfocused discussion. It's not a clinical interview. What I'm describing here is a clinical interview. You have a differential diagnosis, and you're collecting information specific to each one of those diagnoses, because you're going to come up with a return of a diagnosis about what the pathology is. Diagnosis means the same thing as identify. We must first diagnose what the pathology is before we know how to treat it. We must first identify what the problem is before we know how to fix it. So the clinical interview is coming in saying what's the problem, and then we systematically collect information to identify the cause of the problem, diagnose the cause of the problem. And the first thing we address when on an assessment is what category of pathology are we talking about? Are we talking about depression, anxiety, ADHD, autism, schizophrenia, bipolar? What's the category of pathology we're talking about? And so with this, that's number one, uh, attachment suppression towards a normal range parent. We're talking about an attachment pathology problem in the love and bonding system. We're not talking about ADHD or autism or substance abuse. No, we're doing an assessment for an attachment pathology. And it's a severe attachment pathology. A child's rejecting a parent. The only cause of severe attachment pathology is child abuse by one parent or the other. So we're into a risk assessment for possible child abuse to the differential diagnosis. Is the targeted parent abusive? If not, then we look to the allied parent. Is there a psychological child abuse and shared persecutory delusion and false, factitious attachment pathology being imposed on the child for secondary gain to the allied parent of manipulating the court's decisions regarding child custody and to meet the pathological parents' own emotional and psychological needs. I am really getting tired of saying that every time I want to say the pathology. I would prefer to say ABPA. We can call it BOB, brutally obstructed bonding. But I get real tired of saying that whole thing every time I have to describe the pathology. But if I don't say that, then the ignorance out there will say Dr. Childress has some sort of new theory. No, I don't. It's the application of knowledge and its ethical practice under 2.01 and 2.04 that they are just so ignorant and incompetent. I have to explain the pathology that they're working with to them. I should never have to explain to a doctor about the pathology they're working with. That's a boundaries of competence issue. If I have to teach the mental health person what the pathology is, that's a violation of boundaries of competence. They need to be gone. They need to go learn and then come back. You're not allowed to come here if you don't know what you're doing. If Dr. Childress has to educate you, you don't know what you're doing. Now, that will mean everybody leaves ultimately. And the clinical psychologist won't come to the family courts. It's too dangerous. It's too dangerous for me to be here. I got sanctioned by the licensing board, by the forensic psychologists on the licensing board. If they're going to sanction me, they'll sanction any clinical psychologist who comes in and shows them up and exposes their ignorance and incompetence, tries to do something about this. And the courts are just too delayed. The courts are not functional right now in their response. So clinical psychologists are not going to put their license on the line to work in the family courts. And forensic psychologists are the worst imaginable. Parents have to explain the pathology to the forensic people. So there's no mental health services in the family courts, no competent mental health service. That's a massive failure to the judges and the court system, the legal system, that professional psychology is providing no competent mental health services to these families in the family courts or to the judges and courts. That's an abomination. That's a disgrace. So where's the APA? Get the APA over here. We need to figure this out and get these parents some real psychologists who know about applied behavioral analysis, who know about dialectic behavior therapy, who know about the attachment system, who know about delusional thought disorders, and who care about being competent. And not just competent, we should actually be cared about like applying the best knowledge. The decisions by the judges in these cases have huge consequences for the child. These are monumental decisions that the judges face. We, in mental health, we should be giving them the best quality of information, and we should be giving them information that they can rely on, especially when there's child abuse as a consideration. We, mental health, professional psychology needs to be returning to the family courts a diagnosis that the courts can rely on relative to child abuse. Which parent is abusing the child? That's always the differential. It's going to be one parent or the other, and that's for 40 years. If we haven't, in these cases, if we haven't gotten a child abuse diagnosis, then that's been misdiagnosed, because that's one way or the other. That's the diagnosis. So if they're not returning a diagnosis of child abuse one way or the other, they are failing in their duty to protect. If you leave a child with an abusive parent half the time, then the child's being abused half the time, and that's a failure in your duty to protect. This is child abuse one way or the other. They need to return a diagnosis of child abuse one way or the other. Now, everybody fights in the courts. I get that. That's the adversarial system of the nature of the beast. But we don't want to be fighting about the diagnosis. We want clarity that the courts can act on. So that's where I recommend telehealth consultation. That all assessments, all of these assessments, should be get a second opinion consult on, and doesn't have to be with me, just two people. And you can put somebody in the room through telehealth watching, and then the other person conducts the interviews, and then they can get together and come up with their joint opinion and document the symptoms here. Once we get clear documentation of the symptoms, we can then make the diagnosis. If the three diagnostic indicators are not present, if this is not a normal range parent, targeted parent, if they're an abusive range parent, then the child abuse is the targeted parent. If they're a normal range parent and the child has narcissistic symptoms and the child has a delusion towards the normal range parent, then it's psychological abuse by the aligned parent. And how do we know it's a normal range parent? Well, tell me, are they a normal range parent? If it's one or two, we'll put that on a treatment plan. We won't worry about the allied parent until we get this under control, until we get them down to a level 3 or 4 parent, normal range parent, and then we should be able to fix things relatively easy. Fixing attachment pathology is easy with a cooperative parent. With a cooperative parent, my treatment plan for severe attachment pathology would be about 6 weeks, potentially less, with a cooperative parent. It's an easy fix. Watch Ed Tronick's still face on the breach and repair sequence. And so you have the initial part that's a lot of breach and repair, kind of sloppy give and take. That's in the normal range. Then Tronick has him go still face, creates the breach. You see the child's protest and efforts at, because it's a goal corrected motivational system. The child's always seeking to maintain that bond. So the child tries various strategies to re-engage after the breach, and then just loses it, because it's a very devastating inside, the grief and the dysregulation that happens to a child in a full breach. So what you're seeing during that, when the child's protesting, that little infant, that's actually emotionally going on in all of the children in the family courts. They're just not showing it. It's just inside and covered, because that's how the brain works. We see it in Tronick's work. So all that distress, that grief, and that's in these childs from that breached attachment bond to the targeted parent. We need to fix that. Holy cow, that's we need to fix attachment pathology, always. And so, but then watch the end of that, when they say, okay, you can stop because the child's losing it, and the mom comes back in, how quickly that child rebonds back into her, What she does is she brings empathy for the child. She doesn't try to re-engage the child in playful stuff. She comes in on the sadness and starts to nurture the sadness. She shows empathy for where the child is at that point, and boom, the child is right back into that relationship because it is so easy to fix, okay, with a cooperative parent. The problem with abusive range stuff is you don't have a cooperative parent. They have unresolved trauma that keeps them kind of locked into their own narcissistic place. And so child abuse is by a narcissistic parent. Okay, that's a fact. So if it's is a targeted parent a narcissistic parent, or is the allied parent narcissistic spectrum? And you get borderline in that as well. So, with that, and so session 5, I meet with the parent, get their response. Session 6, I meet with the targeted parent, just kind of keep balance, and I present them with the treatment plan and my recommendations. 6 sessions, I can do the diagnosis. I can do it in less, but I would recommend that this just become a standardized approach. And then when you get telehealth consultation, everybody, the mental health people are using the same language. They can add language. They can add whatever you want. You can add, Kohut and self psychology. You can add, internal family systems work, or, emotionally focused therapy. Whatever you want. Just as long as it's actual knowledge and it's got research support to it, and so, but this will give us the framework, give the incompetent mental health people the framework, as we scaffold into knowledge. The assessment for delusional thought disorder is a mental status exam of thought and perception, and ultimately that should be known by all court involved psychologists, how to conduct a mental status exam. And I would recommend, AFCC, get a hold of Joseph Ventura, author of the BPRS. He's the one who trained me. He's out at UCLA. Contract with him to come do some trainings in the BPRS. We should be doing the BPRS, brief psychiatric rating scale, on all these families and stuff. But crawl before you walk. We're still teaching these mental health people about behavior therapy from the 1940s and 60s, and applied behavioral analysis and family systems therapy from the 70s, and 80s, and attachment from the 80s and 90s. And oh my God, we're not even talking intersubjectivity yet from 2000 on. So these mental health people in the family courts are just ignorant like a rock. I cite to the New York Blue Ribbon Commission on Forensic Custody Evaluations. They need to be gone. All of them need to be gone. They are all child abusers. They are all incompetent mental health professionals. I know that for a fact. And where are the licensing boards? They're corrupted with the forensic psychologists. We got to get the forensic psychologists off the licensing boards. All psychologists should be reviewed by clinical psychologists to maintain a standard. If you want to add more because you're in the family courts, that's great. Add more. But we need a baseline of standard 2.01, standard 2.04. That leads to standard 9.01. And so with that, that's the assessment of attachment-based assessment of attachment related pathology surrounding divorce. So I gave this booklet so that parents can give it to your therapist and say this, so that therapists could read this and then consult with me about doing this. And so that, get on a consultation. Tell me what you're finding. Tell me the symptoms. Tell me what's going on. And we have a way of structuring the exchange of information and how we're going to process the information, applying the established knowledge of professional psychology. And then I also gave it to, provided to parents so that you can give to the court and say, Your Honor, I want one of these. Good luck finding one of them, but at least I've described. You don't have to describe what the assessment you're looking for. I've described it. Now, the mental health people don't know how to do it, which indicates how bad the mental health people are over here. Dialectic behavior therapists have applied behavioral analysis knowledge, so they'll be able to do this. Intimate partner violence therapists, IPV, the domestic violence therapists, will have knowledge of the narcissistic personality, and so they will and they're stronger, they're trauma people, so they will be able to adapt and do this as well. So those are the two people I would look to bring back, the two communities of clinical psychologists. But I don't think they'll come, and I don't think they should come until it's safe over here. There's no reason for a psychologist to put their license on the line to help people. Nah, it doesn't happen in autism, ADHD, eating disorder. Nowhere else does a psychologist have to put their license on the line. They have to do it in the family courts. That shouldn't happen. So we need to solve this. I've given you a structured assessment protocol. If you don't believe me, if you don't want me, well, then do a pilot program for the family courts with university involvement and develop your own. But just do it. We need a structured assessment protocol so the mental health people can stop fighting about what the pathology is and actually return to the court a diagnosis that the court can rely on for its decision making. And so we need to make that happen, because this is child abuse. It's active child abuse, and it's active spousal abuse using the child as a weapon. So every day in the family courts, we have child abuse going on that's undiagnosed, untreated, and it's driving me crazy because I've been here for 10 years and it's been going on for 10 years. We've had 10 years of child abuse from the colluding mental health people who believe the shared delusion. If you believe a shared delusion, you become part of the shared delusion. You become part of the pathology. When that pathology is child abuse, you become part of the child abuse. You, the mental health person, because of your ignorance and incompetence, become a child abuser because you believe a shared delusion and you communicate to the child that their delusional beliefs are accurate when they're not. That's not the treatment for delusional thought disorders. You do not validate a delusion. That's not the treatment for a delusion. You don't validate delusions as being true. You challenge the delusion as false. That's the treatment for delusional disorders, is to reorient the person back to reality, not for you to enter their false delusional belief. But the mental health people are ignorant and competent in the assessment of delusional thought disorders, so they're participating and including in the child abuse. The mental health people are the child abusers, and that drives me crazy. So next week, I'm going to talk about the contingent visitation schedule. Now, this is something I developed that I think is a really good treatment. It's a strategic family systems intervention that, and again, I provided this so that you can give it to the mental health people, you can give it to the court, say, I want one of these. Good luck finding a therapist who can run one of these. They would need to know applied behavioral analysis. If they know applied behavioral analysis, it'd be easy peasy for them to do this. So school-based psychology is good, but they don't know a lot of the other personality pathology. Dialectic behavior therapists could do this easy peasy. And so that's, if you get them back and a little consultation, just get them to read this, they'll go, okay, I get it. What we need for this is the court to authorize the mental health professional, family therapist, to adjust up and down the visitation schedule based on specific set of criteria that's defined in here. And so we're not giving the mental health person carte blanche to change the custody orders. It's just based on symptoms. If the child's symptoms goes up, the child's time with the pathological parent goes down, and they get more time with the targeted parent. When the child's symptoms return to normal range, then it goes back to the court-ordered visitation schedule 50-50 or whatever that is. And so it's just if the pathological parent produces child symptoms, then their time with the child goes down. And that then deals with the power dynamic of how the symptom is conferring power in the family. That's strategic family systems. So with that, I'm going to wrap up today. Get on to my Sunday here, and next week we'll talk about the contingent visitation schedule. Take care, everybody. Good luck.